He is one of our assistant medical directors. Dr. Eschelbach is in charge of the ER up in Redmond, Oregon. He also is a EMS medical director, speaks on the EMS circuit up there and the conference circuit, etc. He's been with us for several years and always has these wonderful, timely lectures like this one, Heat-Related Illness and Hyperthermia. So just some little housekeeping things. Remember that to get credit, if you need credit for this, you must participate. So what we'll do is we'll mute everybody for now so that your outside noises will not interrupt. But if you have something to say, you can either chat in the chat box or better yet, unmute your microphone and ask your question and then remute it. That way we can hear you, because I know it's hard for the docs to keep track of the chat room while they're also trying to teach and keep track of the slides, because the chat room doesn't show well when you put it up into full slide mode. So with that having been said, Dr. Eschelbach, I'm going to turn this over to you.
All right. Well, greetings, everyone. I'm going to stop my video so you can concentrate on my slides. And Jane mentioned timely, and the reason I'm doing this today is because for some of you, you're probably already past the season for hyperthermia, but as we head into summer, we're going to be, especially even if you're a student, you're going to be or a volunteer with your home department. You're going to be covering certain sporting events and races, etc. And it's good to have all this stuff together. So we're going to, just like in the fall and early winter, we talk about hypothermia. We're going to hit hyperthermia this evening. First off, information about heat-related deaths. And as you can see, we are used to what we call a bimodal distribution, meaning males will suffer this more than females. And I'd be interested, about every 10 years or so, we should be ready to see if there's new information, but you can see that men are usually twice as much, and you'll see they tend to, a little bit different than drowning that we talked about. They tend to kind of go up and peak a while, and then they start to go down. And then here's a very interesting fact. Here in the greater than 65 group, men and women are relatively equal. And the reason that is because of a couple of things. Number one is coexisting conditions, and also medications that might interfere with some of the processes of losing heat. Every year, we have about 700 deaths per year. And as you can see, most of the time, males are twice as much as females until we get to that elderly group, greater than 65. I wouldn't really call them elderly because they're all lumped together, greater than 65, and then they are equal. We're going to talk a little bit about normal body temperature, causes of heat illness, a few easy clinical pictures, treatment, and prevention as we go through this. Metabolism, as we know, the average temperature for humans is about 98.6. That goes up and down a degree. Some people run warm, some people run cool. But in general, that's the best metabolic temperature for metabolism and normal cell function, so we don't get cell damage. The other thing that we have to look at is as temperature goes up, 80, 85, 90, 95, 100, what's very, very important is the relative humidity. And as the relative humidity goes up, as the temperatures go up, then we wind up with more injuries. Heat disorders are, I'll break this down a little bit better. You don't have to read all this, but it's simple fatigue up until heat stroke, which is the most dangerous of all of these. Other heat-related illness are heat cramps, prickly heat, which we'll talk about a little bit, heat syncope, people passing out because of the heat, and then the fine line between heat exhaustion and heat stroke. Heat exhaustion is recoverable with simple treatment, but when we get into the heat stroke category, we really have to up our game and work hard to save that patient's life. Keep in mind that the body is regulated by both metabolic things in the body and environmental causes. And heat loss and heat gain can also be regulated by environmental factors. Heat loss, just like we talked about in hypothermia, comes from 4 sources: radiation, convection, conduction, and evaporation. And we'll go over those in just a moment. Conduction is a transfer of heat by direct contact down a temperature gradient. Convection, just like your oven, is transfer of heat by movement of heated material. And radiation is loss of heat from non-insulated areas. And evaporation or respiration or sweating, you lose heat through exhalation, you're breathing. In general, the greatest loss of heat is radiation between the environment and the exposed body area. This can also be an area for heat gain, which I'll show you in a few slides. So here is our standard guy out hiking on a fall day. And this is how he is getting hypothermic. He is conducting by sitting next to the rock and losing heat from him through the rock. And then radiation is coming off, respiration is coming off, evaporation through both breathing and the sweating. And then as the convection comes along, wind. Now keep that in mind. And then there is also the gaining of heat when you have differences. Solar radiation will gain heat. You tend to evaporate and lose sweat, but there's also reflected solar radiation, thermal ground radiation, and ground conduction. Now, the sources for a lot of the pictures in these slides are from 2 major sources. One is the military, which is pretty obvious, and the other is from the Oregon, Washington, and California Highway Department, who also have a lot of workers who are outside during the summertime. When our troops first went to Afghanistan, way back in 1991, as we are finally leaving there, some 30 years later, when we first went to Afghanistan, they were deployed and expected about almost 3 months of accommodation for bodies to accommodate to the heat, 120 and 130 degrees. Other contributing factors are previous heat injury. You are more prone to get heat stroke and heat exhaustion if you had prior heat injury. Alcohol consumption, alcohol is a diuretic, and it also decreases the inhibitory factors in the body. Dietary supplements or medications, such as Sudafed or maybe Adderall or other medications, fatigue, and then basic skin trauma. When you burn the skin, it loses a little bit of the ability to sweat and let off some of that heat. There are 3 major ways to prevent heat injuries. Number 1 is proper and constant hydration. 2 is wet bulb monitoring, which I'll talk about in a few minutes. And the other is the acclimatization. And this acclimatization is the one that the United States military takes so seriously. We tend to, in some places, you throw a switch. Some places are constantly warm, and other places you throw a switch. It's spring one day and summer the next, and we don't have much time to acclimate. But when we start getting up into the much, much higher temperatures, late summer, July, August, late June, this acclimatization is the one that takes a while. And up to 90 days. So usually by the time the summer's over, your body is much better at dissipating heat. Wet bulb monitoring. If anyone is a runner or a racer, you've probably heard of the wet bulb. It's an index and it's a good indicator of external heat stress on the body. And it usually will help determine race conditions and military training. And if the wet bulb is not proper, then usually a race is canceled. Now, anyone who's ever run a marathon, and marathons tend to be in the fall, and they tend to be late spring, you'll know that you always start marathons at some ungodly hour, like 6:30 in the morning, or usually not much later than 9. Even, the big ones like the New York City Marathon or the Boston Marathon. Boston Marathon's run in April typically, and New York City Marathon typically in November. They start at 9 o'clock or so, but the temperatures don't go up that high. But any other race, like your 10K or your 5K during the summertime, it usually starts at the, 5 o'clock, 6 o'clock, 7 o'clock in the morning. Early on, and that's because they don't want to cancel the race due to this wet bulb determination. Wet bulbs do a couple of things. They measure ambient temperature. They're going to measure humidity, and they're going to give the race director or the drill sergeant, if you're doing troops, an index. And if the index is too high, he simply says, well, we can't do this today. We can't have the race, or we're going to move training indoors or something to that effect. Illness, itself, and high heat procedures usually are triggered at about 95 degrees and higher, but they don't have to be that high. Very often, people who are road workers will have what we call these pre-shift meetings to talk about high heat procedures. And then everyone is asked to keep an eye on each other, like employees, keep an eye on your other workers for other signs and symptoms of heat-related illness. They may ask every 2 hours, mandatory 10-minute cool down. And I don't know what it is about road workers, but I always seem to be driving past when they're having these cool downs. But that's me. Who knows? And employees have to be authorized to be able to call for emergency service if somebody is ill. They have a specific training and written plans for heat. New employees have a special way that they have to go through things, and they have shorter working hours. New employees who are working on the highways, et cetera, those are the people who are observed for the first 14 days to make sure that they can tolerate the heat. And then if there are heat waves, all employees have to be observed. And a gradual increase in work hours is generally what works best to acclimate these workers. Now, there are other workers other than road workers. Think of your fire workers during the summer. These people are subject, they're wearing heavy woolen, usually, clothes, even though it is summertime, because they're fighting fire and they're doing extremely difficult work outdoors and heat situation when there's fire. So these are people who are also under these same types of rules and regulations. Predisposing factors to heat illness is physical activity. You're running a race or you're fighting a fire. Poor physical condition and extremes of age. We already talked about that. Excessive clothing, like our poor firefighters. Dehydration, any underlying cardiovascular disease, skin disorders, like folks who have bad psoriasis, might already have a large amount of their skin that doesn't work as well as others. Obesity and drugs. And all of these drugs, calcium channel blockers, diuretics, amphetamines. Amphetamines could be simply something like Adderall, or your medications for weight loss are also there. LSD, hopefully you're not out there working, but there are other things. Now, keep in mind, one of the people that we tend to neglect are people who are on medications, such as homeless with mental illness. Phenothiazines, which the most common of which would be Phenergan, for example, an anti-nausea medication. And then there's others, such as Thorazine and some of the older antipsychotic medications. That's why, sometimes you'll see some of these homeless folks who, even in the middle of the summer, they're sitting there with a coat on, and they are subject to dehydration and the effects of these drugs. And, the mental illness contributes to that. So these are folks who are also at much higher risk. These are drugs that interfere with thermal regulations. We talked about them very briefly. Thyroid hormone, amphetamines, which, we're not talking about uppers. There are a lot of people on amphetamines who have ADD or something like that, who are on Adderall, which is a combination of an amphetamine and a lexoamphetamine. Tricyclic antidepressants. Some of your older folks, now LSD is not used for anything other than recreational drug, but that can also cause heat production. There are some that cause decreased thirst, like Haldol. That's one of your older phenothiazines. And then some people who are on simple antihistamines and anticholinergics, etc. These medications might be used to treat side effects of other drugs, and they can decrease sweating. And if you decrease sweating, you decrease evaporation, and you get a higher core temperature. Symptoms of mild injury. These are your canaries in the coal mines. These are the people who are starting to show the early signs. And it could be something simple as dizziness and headache, nausea, sometimes vomiting, but just feeling nauseous or unsteady, weakness, muscle cramps, which I'll talk about in a little bit. These are the people who need rest, water, and evaluation. It's some of these folks that you'll see at a big event. You know, you might have to be covering a festival, which is an outdoor concert or something to that effect. And you're going to see people who are sitting down, resting, fanning themselves. These are people most of the time who can take care of themselves, but these are the people that we have to watch. Why do I say canaries in the coal mine? Because if you start to see people get any of these symptoms, you can bet that there are other people who are going to go over the edge and become full-on heat stroke. Prickly heat is one of the simple things. It comes with intense heat, usually with warm clothing in contact or sweating. It's these small, what we call like milial type bumps that are very often associated with the areas that are covered. And usually it's changing of the clothing, washing of the skin, and putting cool on is the best way to get rid of that. Followed by heat rash, which is simple clusters of those red bumps that look like a prickly heat on the neck, upper chest, and in the folds of the skins, like the backs of the knees or underneath the axilla. It's also a very common problem in hot work environments. If you work inside a factory, for example, that has a lot of heat making equipment, you try to get the worker to a cooler, less humid environment and try and dry the affected area, because the beads of sweat have helped contribute to the heat rash and prickly heat. Heat cramps are very often spasms of the muscles, pain. They usually happen in the arms or legs or abdomen, and they can be the very first sign of worsening heat-related illness. Often, again, you have to have the person rest, drink plenty of water to cool them down. These folks are going to have to wait a few hours before they can return to strenuous work. And if they get worse and they don't go away, they may need medical attention. They may need to check their calcium and magnesium in the ER and see if they don't have a low potassium or something like that. Heat cramps is usually caused by a total body salt depletion, and they kind of move all over. They usually don't involve the entire muscle. Usually parts of the muscle are involved in heat cramps. They appear to wander. They might go from arm to arm or leg to arm. And these are the ones that are most common in those folks who are not acclimatized to work outdoors. Usually getting them in simple Gatorade or any electrolyte replacement drink will help these go away. All right. All right, now we're going to move into heat exhaustion. These are the ones that are the ones just before heat stroke, and very, very common in our summer events or in our early spring events where we have an extremely warm day. It can happen where every once in a while it's supposed to be average temperature of 50, and you could have a day it's 90, and folks at marathons or Olympic type races during the summer can be subject to this. Heat exhaustion, these are the folks who just can't go on, and they're unable to continue the activity. They usually have nausea, vomiting, followed by irritability and a bad headache. They can get orthostatic changes. That's a drop of 10 millimeters or more of mercury on their blood pressure by standing up. They can get short of breath. Piloerection is just a fancy word for goosebumps. And they also usually have diffuse sweating. And this is what I want you to observe in these individuals. Are they sweating or are they dry? And if they have gotten to the point where they're still sweating and they're profusely sweating, these are the people who are on the cusp of possibly tipping over the edge to heat stroke, and I'll talk about that in a few minutes. These core temperatures can be up to 102, and orally or rectally, that would be 103 rectally. A rectal temperature would be best, but if you can get an oral temperature, I would avoid skin temperatures because I just don't think they are accurate if you've been exposed to the sun. Treatment is pretty easy. It's rest and then active cooling, which I'll talk about in a minute. Rapid external evaporation with fans and cool cloth. 1.5 liters of saline IV would be a great idea. Or a couple bottles of Gatorade or electrolyte replacement. With this rapid cooling, you try and get them in a shaded area. You wet the entire body. You want to try and get a fan on them to get that convection and evaporation going as soon as possible. Icy sheets, if you've got ice, dump it on the individual. Also cover the top of their head because they're going to lose a lot of heat there, and you want to try and exchange that heat for cold. When the sheets warm up, yank them off and replace them and reapply them, and get that person's temperature down as soon as possible. All right, the next is the killer, and that is the heat stroke. The high-risk groups, again, are the elderly. Now, what happens with the elderly very often is they may be older, they may try and conserve their electric, and they may not have air conditioning in an older home. They've got some of them chronic medical problems, and they take diuretics for their congestive heart failure. So they're tending towards dehydration to begin with. There are some who are obese. Some obese patients have a higher risk because they greater adipose tissue. With the greater adipose tissue, they can heat up warmer. And then, of course, alcoholics. And again, I would add to this category maybe homeless with mental illness. High risk for exertional heat strokes, are small children in closed vehicles. There is a big push on this. And if it's a hot day and you see a kid in a vehicle alone and the door won't open, very often these parents get out of the car and they forget. That's when you break a window. I wouldn't hesitate to break a window, or you call a policeman if you feel like it's not your job to do. But these are the kids who can get very, very hot very soon. Children die every summer because of this. Of course, athletes, military recruits, construction workers, and on hot, humid days. The biggest reason that heat stroke is a killer is because the thermoregulatory mechanism of the brain has been overcome. So at 103 to 105, you can get failure of the hypothalamus of the brain and the thermoregulatory center of the brain. And these people usually have bone dry, hot red skin. They can also have the symptoms of heat exhaustion, like vomiting and diarrhea, but very often they'll have impaired mental function. Sometimes they'll have seizures or even a coma. But the biggest thing is, just like when I showed you that very first picture, if they're sopping with sweat, that's probably an advantage type of thing. But when you get to the loss of thermoregulation, you lose the loss or ability to sweat, and these people are dry. So if they're dry and hot, they're on the next step towards death. They wind up again with abnormal brain function with this elevated body temperature. They can be confused and combative. I would add to this, always check a blood sugar if possible, because if they're confused and combative, it may not just because they're hot, they might be low on glucose as well. These are folks who are tending towards sudden cardiac death or syncope. Differential diagnosis of heat stroke, something called malignant hyperthermia. This is something that happens when you use something such as succinylcholine. This is a very, very dangerous condition. And these people can get to temperatures of 105 to 107. Like if you went to intubate somebody, that could happen at any time, but it's in the differential, meaning things that might be other than heat stroke. There might be a febrile illness going on. There might be some type of pneumonia or COVID or something like that. Could be a stroke. It could be something called neuroleptic malignant syndrome or a drug overdose such as cocaine, amphetamines, MDMA, LSD, etc. These are the questions that you're going to ask yourself in the treatment protocol. Number one, does the patient have a significant central nervous system involvement? Are they staggering, confused, irritable? And if the answer is no, it's more likely they're going down the heat exhaustion route, and hydrate them, remove them from the heat source, and monitor for resolutions. And then did symptoms get better? Yes or no. And then if they get worse, then you might want to go down the heat stroke algorithm, which is ABCs, EMS involvement, IV, etc. Remove the patient from the heat and begin that rapid cooling that we talked about. And in a medical facility in the ER, we'll continue with this core cooling. We'll do other tests like checking the kidneys, for example, to make sure that we don't wind up with kidney function failure and things to that effect. I monitored one of my paramedic groups for one event, which is a marathon that's usually run in June. Central Oregon tends to have temperatures in the 40s or low 50s early in the morning, and it doesn't get warm until you get to the afternoon. And then that marathon is usually started early in the morning, and they're finishing by 11 or noon. However, because of the sheer amount of people who had symptoms, we modified our heat exhaustion protocol, and the paramedics were allowed to start an IV and give 1 liter of fluid and monitor during that time to see if symptoms resolved. If they didn't, they had to be transported to the emergency department. Again, heat stroke treatment on comatose patients, anyone with a Glasgow coma score less than 8. These are the people who need intubation to protect their airway if they're unresponsive. Get them in that total body immersion and rapid cooling that we showed you earlier. About 0.15 centimeter per minute. Try and get rectal temperatures. I know you guys hate to do that, but every time I encourage a paramedic to do that, they're kind of like, not my job, but that's where the most accurate temperatures are. Judicious IV fluids. And in the ER, we're going to monitor their coagulation and acid base status to make sure their kidneys don't go into a problem. Pre-hospital care, cooling is the first priority. You can reduce mortality from 50% in the heat stroke category to 5% by simply cooling them. Drench them with water, get a fan going, iced sheets like we showed you in that one picture, massage the large muscles while they're cooling to facilitate the cooling of the muscles. And if shivering begins to occur, you've probably reached your end unit and you can start to back off just a little bit. Again, I like to show this more than once. So as you're talking to family and friends, you're going to find out if there's any medications that the patient is on. And all of these antihistamines, decongestants, blood pressure medications, psychiatric medications, all of these can interfere with thermoregulation. So in summary, in general, to prevent heat-related illness, be smart about it, stay indoors and remain indoors. You know, the wet bulb is going to determine whether or not your working is going on or your race is going on. Plenty of fluids along the way. Minimize strenuous activities in the heat of the day. The young and the elderly are the most susceptible to heat-related illness, and they're going to require the most intensive monitoring. All right. That was base jumper in Russia. Okay, very good. I'll take any questions that you might have.
We saw your snowboarder earlier. He was fun.
Yes. Sorry that it didn't play. So I don't know why I threw a snowboarder in heat and this guy also, but who knows?
Christian Weber asks, Dr. Eschelbach, how do you define judicious fluid replacement? How much fluid per kilogram?
Well, if you're talking about a kid, you're talking about 20 cc's per kilo. And if you're talking about an adult, judicious would be about a liter to 2 liters, depending on the situation. So judicious means, usually at least a liter if you're going to start an IV, orally as much as they can tolerate.
Christian said, thank you.
You're welcome.
Omega, are you out there? You haven't said a word or typed anything. We need to get you involved here. Omega says, yes, I'm here. Well, come on, you got to do more than that. And you guys can unmute your microphones and talk. It's a little easier.
I'll go with the question. Do you have any feelings on just if it's like a hot summer day, we're picking up somebody, if you suspect any type of dehydration, going in with a liter?
Sure. Take a decent history. Somebody's got a class 4 heart with congestive heart failure. A liter may be too much, but if they're an adult who's been out, I have been in many, many places where I've walked over to people, and the doctor in me is just trying to determine whether or not this person is with it or not. You walk over to them and see how they're doing, and you can see that they're an older person. Maybe they look a little unsteady on their feet, and you're at the Grand Canyon and you're halfway down the Bright Angel Trail. Then you're going to get more concerned, make sure they're feeling okay. But sometimes it's simple as, a hot summer day and they're waiting for the fireworks to begin, and maybe there was a picnic at 5 o'clock or something to that effect, and they just don't seem like they're doing well. Talk to them, see what their history is. A liter will probably not hurt anybody who's been out exposed to the sun and doing strenuous work. If you're, when I hiked the Grand Canyon, I drank just copious amounts of water, probably too much at one point, to the point where I felt like, I had drunk too much. But I'd rather be, a little bit overloaded with fluids than underloaded. So judicious, what's judicious? A liter of saline is probably not going to hurt anybody if they're warm and showing signs of heat exhaustion.
Earlier, you had mentioned possibilities of us working sporting events, stuff like that. So say we're at a football game, player rolls his ankle. Could that just be a case, get an IV, why not give a liter just because they're sweating and hot?
Well, I wouldn't say with a rolled ankle start an IV, but if it's one of those September games where you get 90-degree days, especially down in Texas or something, maybe. But I wouldn't say.
I'm in the Houston suburbs, just.
Yeah. I'd say, can that kid tolerate oral? Oral is probably better in that particular instance. But if they're having, heat cramps and moving signs and symptoms of heat exhaustion, sure, go ahead and get an IV in there, before they transport, or maybe even, depending on what your medical director says, might be able to give a liter on the sideline and they're out for the game. That might be something that could be tolerable. And it's okay to mention, but if any people have discolored urine, most likely it's called Coca-Cola colored urine. If they urinate and they notice that it's dark brown or Coca-Cola colored, that means that they're getting breakdown of myoglobin filtered through their kidneys, and that means muscle's been broken down. those people need to be transported and treated in the ER.
Dr. Eschelbach, can you talk a little bit about malignant hyperthermia and what your differences in history and physical are going to be versus your standard hyperthermic patient?
All right. Well, malignant hyperthermia, it's in there as what we call a differential diagnosis, things other than heat-related illness that could cause high temperatures. The only time you're going to see malignant hyperthermia is after you've given a depolarizing agent like succinylcholine, and you're going to notice it pretty quickly. And they're going to heat up to 105, 106, 107 degrees. So if you were intubating somebody and they all of a sudden started to heat up, that is most likely malignant hyperthermia from a drug, as opposed to just plain hyperthermia, which is almost everything is exposure and exercise that we've been talking about in this particular scenario.
I know that if we end up with a scenario like that, you know, in the hospital, you guys would give dantrolene, but very few EMS services carry that. So what happens if you end up with you try to RSI your patient and all of a sudden they're 106 and you're freaking out a little bit?
Yeah. The only treatment for this is something called dantrolene. Dantrolene is not something that's in your typical EMS bag. So you're going to need to contact medical control and let them know that you've got somebody coming in with possible malignant hyperthermia. It's relatively rare. It does happen. I throw it into this slide or this lecture because it's in the differential for hyperthermia, meaning what other than heat-related illness can cause hyperthermia. And if you ever run into it where they start to heat up like that, you're going to have to cool them down just like you would a hyperthermia patient, and let the ER know that you're coming in hot with a hyperthermic patient who's possible malignant hyperthermia reaction to your succinylcholine.
Thank you, sir.
You're welcome.
Anything else out there? Going once?
Mm-hmm.
Going twice? Apparently not.
All right, very good.
Awesome. So this was a short lecture tonight. So everybody, thank you for coming. Dr. Eschelbach, thank you very much for being here tonight and putting up with me being a few minutes late.
That's all right.
And we will see you all. I will be getting schedules posted pretty quickly as soon as I can get the messages back out to all the docs for what they would like to teach in June. And then I will be getting them posted. Thanks, everybody.
All right. Thanks, Jane.
Thank you.
Good night, Dr. Eschelbach.